First of all, I would like to thank the Haryana State Blood Transfusion Council and the organizers for inviting us. I welcome you all to Panchkula and Chandigarh. Dr. Atri has already talked about the importance of the factor support and the various therapies which are there in our armamentarium. So I thought I would discuss one more of a clinical and a practical issue which I feel all the hemophilia care providers should be aware of, and that's why we will talk about assessing and managing joint issues in hemophilia. So the topic outline is going to be the components of hemophilia joint care team, the classification of the hemophilic joint disease, pathogenesis, and stage-wise management of the hemophilic joint problems. So what comprises the multidisciplinary team? Obviously, we need the lab specialist who would give us the diagnosis and help us in monitoring the therapy, the hemophilia care physician, the surgeons, the anesthetists, the physiotherapists, the financial support which we all need, and the transfusion support team. So why talk about joint specifically? Hemophilia is a systemic disorder, and bleeding can happen anywhere, in the brain, in the GI tract, in the nose, in the heart, in the lungs. But why talk about joints? Because if we look at the frequency of bleeding at different sites, hemarthrosis predominates and is makes 70 to 80% of the total joint bleeds or total bleeds which these patients suffer with. CNS bleed is less than 5% and muscle bleeds are around 10 to 20%. So 70 to 90% of all bleeding episodes actually occur in the joints, and this actually very frequently leads to permanent joint damage, and it is a reason for disability as well as reduced quality of life. So this is probably Western data which says that 42% of the bleeds happen in the ankle, and the elbow and the knee joints is around 20%. In probably our experience, I would say knee joints is probably the commonest site of joint bleed. And basically, if you look at an adult patient who has hemophilia, even in the Western setting where there is regular profile access, the instability, the flexion contractures, the crepitus, the axial deformities, the muscle atrophy, almost everything in an almost more than 50% all adult patients suffer with these joint problems or musculoskeletal problems. So this is the reason why joint health is probably one of the most important issues in the life of a person with hemophilia. So the hemophilic joint health package would actually, or the assessment besides the joint per se, also includes the assessment of pain, disability, the bone health, as well as the global QOL. These are the components which we tend to kind of oversee or pay less attention to, and that's why this slide where I feel that even these portions should be given adequate attention. So what are the variables which influence the joint outcomes? One is the disease severity. We all know the severe ones will bleed more, the moderate ones will bleed less, but even the moderate ones do bleed, and even they also suffer with joint problems. And secondly is the severity of the mutations which they are harboring. And we all know that what is the impact of the hemophilic arthropathy. So this is the kind of stepwise cartoon which shows what happens inside the joint. So every bleed actually has a clinical consequence, and every bleed episode does leave some irreversible damage to the joint. So it starts with the pain, swelling and loss of mobility. It progresses to structural and inflammatory changes, and finally chronic synovitis, target joint and increased disability. So why this happens is because of the inflammation and hypertrophy which happens in the synovial membranes, and it leads to increased vascularization, and this in turn further increases the tendency to bleed. So these are the three, this is kind of the pathogenesis of the 3 stages of hemophiliac joint disease. It starts with acute hemarthrosis, where the synovium becomes inflamed, hyperemic, and now it becomes extremely friable. So if you don't manage the joint bleed at this stage, this friable synovium will tend to bleed more, and with repeated bleeding, this becomes chronically inflamed and hypertrophied. This is the stage of chronic synovitis, and when it continues to bleed, basically there would be complete articular damage as well as muscle atrophy, and this leads to the 3rd stage, which is called as chronic hemophilic arthropathy. So this is the again showing the same thing: hemorrhage leading to synovial inflammation, recurrent hemarthrosis, synovial hypertrophy. Once the synovium is hypertrophied, it tends to get impinged more while the patient is moving and doing activity, and this synovial impingement will lead to further episodes of bleed, and this would because there would be lot of enzymes and inflammatory milieu, it would erode the bones and the cartilages, and this would lead to an end stage hemophilic arthropathy. At a molecular level, if we see, it is so blood has iron, we all know, and this iron is a inflammatory antigen. So this iron will stimulate various cytokines, particularly IL-6, IL-1 and TNF-alpha. It would lead to increased expression of proto-oncogenes such as c-MYC, and it would also lead to induce other tumor suppressor genes, and this in turn will lead to synovial proliferation. So this is at the molecular level what is going on. So both in vivo as well as in vitro studies suggest that it is the blood which is toxic to the articular cartilage, and this blood also leads to inhibition of proteoglycan synthesis. The proteoglycans are actually so if in vernacular terms, what we say, all our dadajis and dadijis would say कि grease खत्म हो गया. So that's actually the proteoglycan, which is the grease in the joints, and whenever there is blood, there would be depletion of the proteoglycan synthesis, and it would lead to joint damage, and in turn it would also perpetuate a cycle of pain. So first starting with the pain, because that is what bothers the patient the most. So almost 89% of the people with hemophilia say that they recently experienced a pain. This is the physical pain, and around 50% of the people of hemophilia actually are experiencing a constant pain in their lives. So we can correlate how difficult it must be for these patients. So that is why we need to talk about pain when we are discussing in our meetings. So 86% of the patients would experience pain, and 92% tell that joint pain is actually leading to an impediment in their quality of life. And moreover, even in the Western setting, people have said that pain is inadequately managed in up to 75% of patients with people with hemophilia. And the other thing which happens, a phenomena which happens in hemophiliacs is called as pain chronification. So whenever you are inadequately addressing the first painful episode of the joint bleed, there would be sensitization of peripheral as well as central neurons. In the subsequent episode of the bleed, these noxious and painful stimuli will be perceived as increasingly strong. So the first episode is say the pain intensity is say 5 on 10. The next episode, the patient will perceive that pain, even with the same amount of bleed, the patient will perceive a higher amount of pain. So this is called as hyperalgesia, and the other term is allodynia, where even the non-painful stimuli patient will start experiencing as pain. So these two the phenomena will happen if the episode of the joint bleed is not managed adequately. And this pain in turn leads to a cascade of rest and avoidance. There would be lack of social support, social isolation, there would be fear, and all these factors actually are giving the brain a positive reinforcement of the pain. On the contrary, sleep, exercise, neural reorganization and a positive outcome of the joint bleed will inhibit the pain pathways in the brain. So pain chronification is an important issue which needs to be addressed. So next we come how to assess this pain. This is something which probably we need to start doing in our clinics. The manual, the WFH manual recommends using the WHO pain rating score, and it is a 1 to 10 pain rating scale, and we ask the patient to grade his pain on a score of 1 to 10. Generally 1 to 3 are mild, 4 to 6 are moderate, and anything between 7 to 10 is a severe pain, and we actually need to reassess it every 12 hours or 16 hours to see how our therapy has worked. A more complicated scale is a McGill pain questionnaire, which is often used in assessing the pain in people with hemophilia. So this is a more of a 78, it uses actually 78 adjectives to define the pain, and it is scored accordingly. So this is the हिंदी वर्जन ऑफ द मैकगिल पेन स्कोर, जो दर्द के विभिन्न आयाम हैं उनको आप 4 श्रेणियों में बांटते हैं और उसके अनुसार आप दर्द का मूल्यांकन करते हैं. So this we can often we may not be able to use the English questionnaire for our patients, but this Hindi questionnaire most of our patients will be able to respond to. So once we have assessed the pain, so that is one part of it, and then we need to decide what stage the patient who walks into our say clinic or emergency with a joint bleed, what stage is that patient in. So basically, as I told previously, there are 3 stages: acute hemarthrosis, chronic hemophilic synovitis, and chronic hemophilic arthropathy. So we'll go step by step and understand what these stages are. So the first stage is the acute hemarthrosis. We know that 90% of our bleeding episodes are happening in the musculoskeletal system. So often one would wonder why the joints only, why not the other places. So there is this articulate tropism of bleeding. This is because there is absence of tissue factor, the tissue factor or the factor 7, which we often use in people with inhibitors. That tissue factor is often lacking in the joints, and that is why the extrinsic pathway is impaired, and that is why it is the joints which have the highest propensity to bleed. So there are 4 joints which are the most notorious, and they are called as index joints, that is ankle, knee and elbow. So I am sorry, not 4, actually 6 joints. And target joint, we all know, if there are 3 or more episodes of spontaneous bleeding which occur within 6 months, they are called as target joints. So acute hemarthrosis typically starts before 2 years of age. Most of the patient will report an aura which would precede the symptom of joint bleeding, and then the patient would tend to take a position of maximum comfort, which is usually the flexion, and there would be secondary spasm of the surrounding muscles. So this is the acute hemarthrosis. This is the joint which is tender and swollen, which is the hallmark of severe hemophilia. This adolescent guy came to us last week. This again was totally undiagnosed. He was having these repeated episodes of bleeding since childhood. When we finally decided that gave him a diagnosis, and with the help of Ashutosh Ji, we could arrange the factors, and finally we have transferred him to Saranpur for his further care after stabilizing him and optimizing his diagnosis. So how do you define a joint bleed? So if a patient, so it is, the definition is totally a clinical one, any unusual sensation of aura with either an experience of increasing swelling or warmth of the skin over the joint or an increase in pain would actually classify for a joint bleed. So with this, there would be a progressive loss of range of motion, or the patient would complain of difficulty in using that limb as compared with the baseline. So if this definition is fulfilled, we would presume that this patient has recently or acutely bled in his joint. Target joint I have already told you. So the goals of treatment at the acute hemarthrosis stage would be first is to stop further bleeding, give adequate pain relief, and then finally rehabilitate. We all know the price, which is protect, rest, ice, compress, and elevate. So this price should be administered within 2 hours of the joint bleed, in addition to the adequate clotting factor concentrate. So how do we practice price? First is protection. We kind of offload the joint for that time. We ask the patient to rest, and this is a partial and temporary immobilization. Typically it is done in the or a 50% flexion position. Then application has to be done within 6 hours, every 10 to 15 seconds for 15 minutes, then they can repeat 2 to 3 hourly. This, for the first 6 hours of the joint bleed, we recommend ice application. We can use these compression bandages to kind of support the joint, and then we generally recommend that the joint should be elevated. If it's not always possible, but generally they say you should try to elevate it up to the heart level or maybe above the heart level. The price often, because it has a component of rest, sometimes people continue to give rest even when the pain has subsided. So now this acronym is actually being changed, where it is the rest is actually replaced by optimal loading. So the newer acronym is PULIS, which means protection, optimal loading, ice application, compression, and elevation. So once the joint, we have done the price, we have given the clotting factor, then the next step is to start the optimal loading, which often we tend to fail, and that is why I have included a separate slide on this. So when to start? The optimal loading should be started as soon as the pain and swelling begin to subside, not at the time when the patient is in active pain. How to start? You start first with the change in position of the affected joint from a position of rest to a position of function, gently and gradually, and increasing the mobilization of the joint. And so whenever there is a hip, knee, or ankle bleed, they should be offloaded initially, and the patient should be restricted from weight bearing until complete pre-bleed joint range of motion and function are restored. These are lines I have taken from the WFH as well. So usually we avoid weight bearing for 1 week, and this is done with the help of either a crutches or a walker, and then you can, the pain is a very sensitive marker, and if the pain has subsided, that should be the signal when the patient should resume the weight bearing. So simultaneous to the price and the subsequent offloading, the most important component is to stop further bleeding into the joint space, and this is where this is done by replacing or injecting the clotting factor, and the patient usually, as soon as the patient has recognized that aura, that warmth in the joint, it is the time that they should immediately inject the clotting factor. How much clotting factor to infuse? I hope most of us are aware of this. We tend to use the low dose practice pattern for the joint bleed, and we know the calculations of doing these things. So this is the EH, if you are using the extended half-life product, this is the dosing recommendation. Again, they are mentioned in the package inserts and the manual as well. This is the dosing recommendation for hemophilia B. So sometimes there would be situation where you would actually need to arthrosynthese or aspirate the joint. Particularly, so in our setting, if it is a septic arthritis, we almost, I would say, once in every 3 or 6 months we end up aspirating the joint, and we have aspirated frank pus from the joint, because septic arthritis is quite, I would say, not uncommon in our situation. So, so what are the indications when we should attempt to aspirate the joint? So whenever it is a bleeding, tense, painful joint which is not showing any improvement 24 hours after conservative treatment, and there is an excruciating pain which cannot be alleviated, or if we are feeling that there is an evidence of neurovascular compromise, there is impending gangrene, and there are disproportionate signs of infection, which means the patient is febrile, or if you are clinically suspecting a septic arthritis. So usually they recommend that inhibitors should be ruled out, and you should do it under factor coverage. So, so it is not recommended for all diseases. There should be, these are the guidelines. You should use a large bore cannula, 16 gauge. It should be done in experienced hands. We usually ask our PGIMER colleagues or the ortho colleagues to aspirate the joint. It should be done in a strictly sterile fashion, and once you have aspirated it, the joint should be completely immobilized for at least 1 hour after the aspiration, and all this should be done under the cover of clotting factors. In addition to giving the clotting factors and giving the price therapy, you actually need to give the pain relief or analgesia. So there is a step ladder pattern which you use, and the WFH recommends that in patients of hemophilia with severe pain, you should be not kind of refrain from using opioids, because most of them would require it. So you start with paracetamol. If that is not effective, you use, I personally use etoricoxib a lot. In mild bleeds it does work, but if it is not working, you can try oral codeine or oral morphine. You start with a slow release tablet, which is usually available, and when you are using NSAIDs, you should actually kind of be aware of hypertension and renal dysfunction, which can happen if it is used very frequently. So, in your prescription of joint bleed, in addition to clotting factor, I would say you should take care of writing one analgesic, maybe etoricoxib or Codcalm or Ultracet, and if no relief, then maybe oral morphine, which is usually available in most of the, though there is a format, form 16, which you have to give, but that it can be given. So in chronic hemophilic arthropathy, beside analgesia and the other things, there are other techniques which this is mentioned in the WHO manual. Meditation, distraction, mindfulness, and even music therapy can be used to alleviate them of the pain. So once we have given our prescription, the next thing we actually need to assess is how good we perform in alleviating the patient's pain. So these are the definitions given: excellent, good, moderate, and none. Excellent is complete pain relief within 8 hours. Good is significant pain relief. Moderate is modest pain relief, and none is no pain relief. So accordingly, we can intensify our clotting factor support, and we can intensify our analgesia. Once we have done all that, after 48 to 72 hours, there is a very important role of physiotherapy. So how do you start physiotherapy? The first thing is you attempt to change the joint position as soon as pain and swelling subsides. You gradually reduce the flexion and strive to attain the extension of the joint. You can do it either passively or actively by gentle passive stretching, or asking the patient to for an active muscles effort. And once this is attained, gradually you move to the next step, which is active muscle exercises, so that the pre-bleed range of motion is attained. Again, this should be done ideally in the cover of factor support, and basically if you have trained physiotherapists, they would do a wonderful job here. So these are the various post-bleed rehabilitation which should be encouraged, and they are beneficially all. So this is the acute joint stage or the acute hemarthrosis stage. But very frequently the patients land up in the chronic synovitis stage. So how do we define that? If the acute bleeds are usually not managed and subclinical bleeds continue for 3 months, and the patient has come with a permanent swelling and he says this has been there for past 3 months, this is, and on palpation this you can actually feel the friable synovium. This is actually the chronic synovitis stage. How do you manage this? So chronic synovitis is happening because of the chronic inflammation which is going on in the joint. So there can be non-operative as well as operative ways, or I would say invasive ways to do it. The non-operative method, which probably in all chronic synovitis states, if we are practicing an on-demand practice pattern, is that you give them at least a prophylaxis for 6 to 8 weeks. So twice or thrice weekly short-term prophylaxis for 6 to 8 weeks if the patient has landed to you in a chronic synovitis stage, and in addition you give them physiotherapy and you give a COX-2 inhibitor, a toricoxib or a celecoxib to reduce the inflammation here. Here we are using the COX-2 inhibitor to reduce the inflammation, and obviously it will help in giving analgesia as well. If these symptoms persist beyond 6 months, then this is the indication where you would probably need to be invasive, and the invasive methods are to do a radiosynovectomy, which is preferred. If radiosynovectomy is not available at your center, you can attempt a chemical synovectomy. If that is also not feasible, you can approach your orthopedic colleagues to ideally do an arthroscopic or an open synovectomy. So radionuclide synovectomy actually means intra-articular injection of a radionucleotide, which would cause the sclerosis of the synovium. Generally a beta emitter is used, and most frequently deuterium at our center, even for non-hemophilics they use deuterium, or you can use the phosphorus 32. So there are certain drawbacks of this. They can cause antibodies which are there, and some risk of neoplasia. So these are the complications. If that is not available, you can actually inject rifampicin or rifamycin into the joint. We have not done this, but it is reported. Sometimes if there is a lot of pain and inflammation, an intra-articular injection of steroid can be used, but this is more of a palliative measure which is used. Hyaluronic acid injections, they have been tried, but not very efficacious, I would say. And if this is not working, you can use an arthroscopic synovectomy, which your orthopedic colleagues will do. However, if the patient has progressed to the third stage, which is called as the chronic hemophilic arthropathy stage. So what is that? This is a stage where there has been a permanent stage of articular damage and joint erosions. This usually happens in the second decade of life in people where prophylaxis was not offered. So when the patient has come to you in a chronic hemophilic arthropathy stage, you would use, in fact in most of your patients you would use various clinical and radiological scoring systems to actually assess the burden of the problem. So, so there are various imaging modalities which are there, which actually the ideal one is an MRI, and we can also use ultrasound and X-rays to do it.